All right. Hello, everyone. Yate, Shikido Shidane, She Corina Sabiku, Yenishe, Pachin Inishle, Hawatlana Bushishteen, Tohaglini Dashache, Maidishkini Dashanella. Good afternoon, my friends and relatives. My name is Corina Sabiku. I am Navajo and Jemez Pueblo. I'm from the Red Running Into the Water clan, born for many Hogans. I'm a senior research program coordinator here at Mayo Clinic, located in Rochester, Minnesota. I want to welcome you all to our Indigenous Health Topics Speaker Series. So as part of our Native American community outreach efforts to engage tribal health, we host this event, which is focused on hosting speakers who are local, regional, and national experts in health, education, and research. All of our presentations are focused on topics that have an impact on our American Indian and Alaska Native communities. We do record most of our sessions and have them posted on our external and internal websites. I want to thank you all for joining us today. I just want to go over a few housekeeping items before we go ahead and get started. So we will have time at the end of the presentation for Q&A. I believe we're going to post a additional web link for an informal discussion between 1 and 1:30. So my colleague Guthrie will be helping get that set up. And if you do have any questions, feel free to add any of those in our chat. And so today I'd like to introduce our guest speaker, Selena Thomas. I'm really excited to have her as our guest speaker today. She's a good friend from Arizona and is one of our American Indian Alaska Native patient navigators at the Mayo Transplant Center. With that said, I'm going to go ahead and pass it over to Selena.
Selena Thomas Inchia. Tabahan the Shons, what's on the Bashish chain, and the Maki Dashi Che, the Kia Ani Dashinel. Twahatle de Yizinasha. Akut Adenes Sun Mission. Hello, everyone. My name is Selena Thomas. I am the patient navigator here in the Transplant Center. I'm over at the Mayo Clinic on the Phoenix campus. I just introduced myself in Navajo. My clans are Edgewater, and I am born for the Big Water Company. My maternal grandpa is one who walks around, and my paternal grandfather is Towering House. I am originally from Indian Wells, Arizona, and I am so happy to be here. I do thank Karina for the invite. So let me start here. I'm in a new area, so please forgive me for trying to navigate this. Sorry. Okay. And everyone can see my screen, correct?
Yes.
So like I said, I am the patient navigator here at the Mayo Clinic on the Phoenix campus. I've been in this role for a little over a year now. I just introduced myself, like I said, in Navajo. I introduced myself, and my plans. So this is who I am. I had mentioned that I am originally from Indian Wells, Arizona. So Indian Wells is on the Navajo reservation. As you can see, it's highlighted there at the top. For those in Arizona, Flagstaff is just right over here. And if you get on the I-40, Holbrook is here. So Indian Wells is just, 30 minutes north of Holbrook. The community of Indian Wells is just located on the most southern part of the Navajo reservation. So I just wanted to talk a little bit about my family. This just gives you an idea of who I am and what I do today. And makes a big impact on the community that I serve. So as you can see, my mom up there on the left-hand corner, she is a huge reason, and one of the reasons that I enjoy doing what I do. We have a very close-knit family. The picture on the right is my mom and my grandma and my sisters. They are a big influence in what I do and who I am today. The bottom picture is my 3 children. Very proud of all their accomplishments, and I'm sure they are. I know one of them is watching right now, so I'm very proud of them. So this is just how, as natives, we like to introduce ourselves. We like to give a little background of who we are and what we do. So, like I said, I am a patient navigator right now, but I've been at the Mayo Clinic for over 10 years now. I started off as a medical assistant in nephrology. I was there for about 5 years, and then I transitioned over to infectious diseases, where I was a medical assistant again for another 5 years. My current role just started in March, the very beginning of April of 2022. I was approached by a colleague who I used to work with in transplant, and they were having some issues with a Navajo patient that was here for transplant evaluation, and she knew that I spoke Navajo, and she knew about my background, so she had asked that I come and try to help, and I did. And that's where the questions, she started asking, why don't we have anything, for a lot of these Native patients that come to Mayo Clinic? Why aren't we trying to help them? There's, definitely barriers there, and she wanted to explore those. So they requested, funding, a special grant from CPC Innovation, and this role was implemented. So at first it was just a temporary role, just to see what kind of impact it would make, just to see if it would make a difference. And it did. So my role was officially approved, and is now a permanent role here in the transplant center on the Arizona campus. There are other patient navigators, similar to what I do. In this facility, there is a patient navigator in the cancer center, and she does similar roles as I do. But I feel like this is something that Mayo Clinic has needed for quite some time. So I'm very happy to be here. I am also the chair of a newly formed Mayo Employee Resource Group here on the Arizona campus. It is called Supporting Indigenous Peoples, and we just had our first member meeting yesterday, actually. So that is very exciting. Over the time that I've been here at Mayo, I had not seen any type of representation for the Native community. And that's something that I've been looking, to try to change, within the Mayo enterprise. And, it's been a while, but I'm glad that we're here now, and we have, established this newly formed employee resource group. And I'm glad that I'm happy, excited that, the patient navigator role exists here now as well. So I just wanted to also talk about the tribes that are here in Arizona. We recently, last year, we set up a table as part of Native American Heritage Month, which is in November. And, we were, talking to employees, in the hallway, just kind of, bringing awareness and just providing information about the tribes here in Arizona. And not a lot of employees, knew how many tribes were here in Arizona. In fact, they were shocked that there were 22 federally recognized tribes here in Arizona. And as you can see, there's, a list there and a map of, where these tribes are located. And I also just wanted to emphasize that each tribe is unique in their languages. They are unique in their customs. Not all tribes, speak the same language. Not all tribes, practice the same, customs. They're all different. So just something to think about, when you're talking with American Indians. So I just also wanted to, before I start, the presentation, I wanted to share a video that I came across. I met an individual at a tribal health summit just a few months ago, and she was talking about a video that she had made or prepared for the Tuba City Regional Healthcare Center. So Tuba City is at least a couple of hours north of Flagstaff, Arizona, and it's on the Navajo Reservation and very close to the Hopi Reservation as well. So this video just talks about the struggles that Native patients go through just to get healthcare, specialized healthcare sometimes. And this video is more focused on cancer treatment, but I think it also can be used, just as an idea of how Native patients how far they have to travel just to seek treatment. So if you could play the video, Guthrie, that would be great.
When our patients learn that no hospital in the area offers comprehensive cancer care, we know they need to go great distance.
Today is another day. When the sun comes up, I rise to greet the holy ones in the morning. I live here my entire life. This is home. Some of my neighbors are nearby and some further than 15 miles away. First things first, keep the fire burning, like most people on Navajo. We have no electricity, no running water. I must check my water tanks. I may have to haul water from the community pump 20 miles away. I feed my animals before I eat because sheep are everything. They are what we eat and what we eat, who we are. I complete the rest of my morning ritual outside. Breakfast, like most meals, comes from a can or a box. Except the animals we butcher, the food we can grow, and the food the public health nurse drops off when she can. But today is not a normal day. I have to go to the next round of chemo because several months ago I was diagnosed with late-stage cancer. The nearest oncologist is 200 miles away, which is as far from New York City to Washington, D.C. If I leave now, I can hopefully get to my afternoon appointment on time, assuming I can get to the paved roadway after 10 miles of dirt road. Rain might have turned the dirt into impassable mud bog like many times before. My oncologist says I will need to make this trip 30 more times before I'm done. It is a shame there is no cancer treatment on Navajo Nation or any other Indian nation. I wonder how many back east would like it if there was no cancer treatment where they live. I drive past Tuba City Hospital every time I go to chemo. The folks who work there share my culture and speak my language. A traditional healer works with the medical staff. Their public health nurse could provide me with in-home follow-up care if they had a cancer center. How many other people have suffered like me? How many other Navajos have gotten cancer and had to travel hundreds of miles each way to access treatment? No one knows, because the Indian Health Service does not collect cancer data from Arizona. But here's what I know. No other Americans are expected to travel 8,000 miles to access cancer treatment. No other Americans are treated like this.
Thank you. So I just wanted to show that video just to give you an idea of the travel that some patients do have to make just to come here to the transplant center. So, sorry, so like I said, one of these, so this is the map that I provided for the tribes here in Arizona. And one of the stories that I want to share with you right now is, after watching that video, one of the things that I do is I help patients with, based on their insurances, a lot of patients have Access, which is the Arizona Medicaid program. One of the programs under Access is American Indian Health Plan. And American Indian Health Plan, fortunately, helps with lodging and meals for a lot of Native patients that travel here for appointments. Some of these appointments can last for a few days. So usually they'll contact me and say, I have appointments coming up, and I'll go ahead and submit the request. So just recently I submitted a request for one of my patients, and the response that I got back. So this patient is traveling from San Carlos, which is on the reservation just near Globe, in that area, Globe, Arizona. So I submitted the request, and the response that I got back was, it looks like this patient is only traveling 2 hours from Mayo Clinic. And it seems that the patient can travel each day for these appointments. And it just, I was like, am I reading this right? And it just, it really upset me. And so I had to respond and say, the patient is also on dialysis, and I had to explain the whole situation to this individual. And so finally, after several, emails back and forth, he was finally, approved. But, who wants to travel, every day, 4 hours, both, in a whole day, just to come for appointments. And I didn't quite understand that. So just something that I wanted to share with you. And,
Selena, you'll need to share your screen.
oh. Can you see now?
No, not yet. There you go.
So this is just a table that was created by the Arizona Transplant Data Analyst team, Katie Harris and Efren. So this just shows the amount of referrals that the transplant center receives for American Indian patients. As you can see, in 2020, there were a total of 142 referrals. In 2021, there was 192. And in 2022 to 27, and then right now, as of yesterday, there were 196. So this is throughout all the organs. So kidney, heart, liver, pancreas. I'm having a hard time, guys. I'm so sorry. So this is just also another slide where these are all the transplants that have happened. These are all the transplants that have happened. Like for the year of 2020, there were only 26 Native patients that were transplanted. The green is heart transplants, liver is this light blue color, and then kidney is this dark blue color. So kidney transplants were 22 that year, liver only 2 patients, and then heart 2 patients. And then in 2021, this is 15 kidneys were transplanted. So a total of 8 organs were transplanted that year. And then going forward in 2022, a total of 35 were transplanted that year. And then currently there have been 26 patients that have been transplanted. So when I meet with patients, what I do is I provide this exact same diagram to them, because I know a lot of patients are visual, a lot of Native patients, or any patient for that matter. But I feel that this diagram here works best with the patients that I work with. So this is the transplant evaluation process. It all starts with a referral. Referrals are sent by primary care physicians. They're sent by dialysis units. So what happens is once a referral is sent to our transplant center, our medical assistants process that referral. It needs financial authorization from the patient's insurance. We also need to obtain records, and also once those are obtained, then the nurse coordinators reach out to the patient and they ask them a number of questions prior to scheduling more appointments. So once they go through that process, orders are placed for scheduling. So usually when I try to get involved as soon as a referral is sent to us. I do have, we do work with Epic as our electronic medical record system. So I run a report and I look to see who was referred. As soon as I see that, then I'll reach out to the patient and just talk to them about that referral. One of the things that I emphasize or I make sure of is, asking these patients, did you know you were referred for transplant? And most of the time they say yes. Sometimes they just kind of, I don't know, I was just told by the doctor that I'm being referred somewhere. I don't know where, I don't know for what. So then I go through just talking to them about transplant. Saying, do you know what a transplant is? Do you know what happens during a transplant? And most of the time they know. So that's, the first call that I make. And then I talk to them about scheduling. I talk to them about their appointments. I say, it looks like you're scheduled on this day. Do you have a way to get here? Do you have someone that can bring you? Do you have, I know a lot of the insurances, especially with Access, they provide transportation. So I ask them, how are you getting here? Who's bringing you? Are you coming alone? And most of the time they say, yes, I have a driver, I have my own car. So that's one of the things that I talk to them about. And then if the appointments happen to be over a few days, sometimes that's where the lodging and the meals come in handy. And I talked to them about that. So where are you going to be staying? Do you have family here in the Phoenix area? Are they an option? Can you stay with them while you're here? So, and then when I talk with them, I also try to confirm, phone numbers. Phone numbers are important because it's a way that the transplant center stays in communication with these patients. Good phone numbers are important because once they get listed for transplant, then they could get a call at any minute. They could be listed one day and they could get a call literally the next day. So I always emphasize the importance of having a good phone number, staying in good communication with the transplant center. And I always provide my phone number in case they have a hard time, getting connected with the transplant center. It's a huge center, and there are so many different departments, and sometimes it can be frustrating when you're trying to call, especially if you're in a rural area and you don't have good phone service. Some patients that I talk to have to, drive a bit, a little out of their way in order to make a phone call or receive phone calls. Some of them have to, hike up little hills and, just to get good phone service. So I talk to them about that as well, making sure that they have, a good phone number and someone that we can contact in case they're not reachable as well. I also discuss with them the option of the patient portal. I know a lot of patients that I talk with do not have phones that support this. So that's one of the subjects that we talk about. Ask them, what kind of phone do you have? Are you able to watch videos? Are you able to do any of those things? Do you know what Zoom is? Do you know how to download an app? Those are things I talk with them about. And do they have Wi-Fi? Do they have a place where they can connect to Wi-Fi? So I know a lot of Mayo likes to promote the patient portal, but the patients that I talk with, not a lot of them are tech savvy. Not a lot of them have someone, family or children that can help them navigate the app. So I don't try to push it on them. If they prefer, getting their itinerary in the mail, then, I try to make that note in their charts, and, they don't want any offers of patient portal. So that's one of the things that I discuss with them as well. So in the evaluation process, this is when they get scheduled for all their appointments. Sometimes appointments based on, the questions that they answer during the intake call with the nurse. Scheduling can take, the appointments can be 2 to 3 days, sometimes a week. Patients are here. And then as they go through the evaluation process, sometimes they get appointments added on. So those are things that I want them to be aware of. So once they go through the whole evaluation process and there isn't anything else that needs to be done on the patient's end, then their case goes to committee review. At that committee, it's several people that are involved in that committee: doctors, surgeons, social workers, nurse coordinators. There are so many people involved, and they all have a say in whether or not this patient gets approved. So the outcomes are usually approved or approved pending, deferred, and denied. So if a patient gets approved, then they get on the list, they get listed, they get on the wait list. They have to stay active in order to be eligible for an organ offer. Usually what happens is they do blood work every month. They have to come here yearly, I believe, to do testing and to, stay current with all of that. So that, that's how they maintain their active status on the wait list. And then eventually they get a call for an organ offer. As soon as they get that call, these patients have to be here within a certain amount of time. They usually are told, you need to be here within 2 hours, or you need to be here within 4 hours. It just depends on where the organ is as well. The hospital stay after transplant usually is like 2 overnight stays. And that's mostly for kidney. I know livers take a little bit longer in the hospital. But after they've been discharged from the hospital, then they have to stay within an hour's drive of Mayo Clinic. They cannot go home, especially if they live, more than an hour away from Mayo. They have to stay within the boundaries here. Only because there's going to be a lot of appointments. There's going to be lab work. A lot of these appointments start like at 6 or 7 in the morning with labs. So they usually want the patients to stay at least 6 weeks after transplant. So that's the process of the evaluation for transplants. So I'm not an expert on how Indian Health Services works, but these are just a few things that I wanted to share with you. So the Indian Health Services was established in 1955. The federal government is obligated to provide healthcare to tribes in exchange for land. They signed treaties with the tribes, and the government said, we're going to take care of you with healthcare and education. And then also, IHS is not health insurance. Growing up, I remember filling out permission slips for school, and there's always a section there that says insurance. And we all wrote, all the Native kids always wrote IHS, it was all, and we didn't know that it wasn't health insurance, but that's the only form of healthcare that we know of. I grew up, going to IHS. I still go to IHS. But it's not health insurance. And sometimes the questions I get are, will IHS cover lodging and meals for some of these patients? And they don't. So that's something that I wanted to share. And then one startling statistic that I came across was that the United States spends more on healthcare for prisoners than Native patients for American Indians. So that's just something that I wanted to share about Indian Health Services. Some of the barriers that I encounter when I talk with patients is, like transportation. A lot of the roads, as you saw from that video, a lot of the roads out there are not paved. There are dirt roads sometimes when the rain comes, and people cannot travel anywhere until a lot of that road is dry again. One of the examples that I wanted to provide you with is I have a patient that I met with early on before he got transplanted. He lives in White River, Arizona, which is on the White Mountain Apache reservation. He lives in White River, and he needed dialysis. And the local dialysis units didn't have a chair for him. So they referred him to Winslow, which is 113 miles away. So he traveled 3 times a week to dialysis because there wasn't anything closer to him. So those are some of the distances that patients travel just to try to get help. Language is another barrier. When I first call patients, I usually, assess for the need of an interpreter. If I talk with the patient, I speak Navajo, I speak conversational Navajo. I cannot interpret, medical anything. So a lot of the conversations that we have are mostly conversational, and sometimes I do try to explain to them what's going on if they have more questions. But I usually assess the need for an interpreter, when I make that first phone call. If a Navajo interpreter is needed, or a Hopi interpreter, or an Apache interpreter, then I have to make that request a couple, at least a week or 2 ahead of time, because there isn't always an interpreter available here. We have the iPads that have language services, but there isn't always an interpreter available. So I always try to schedule that ahead of time. I know a lot of patients don't like the phone interpretation because it's hard, you know, to try to listen to somebody and then also listen, you know, try to understand what the provider is saying and then wait for the interpreter. So that I know, you know, from experience that patients prefer like an in-person interpreter, and it's more personal, and you know, they get to, you know, talk with the interpreter and you know, introduce themselves and, you know, have, you know, a little conversation before the interpreter starts doing their job. Finances is also another barrier. A lot of patients are on disability. Some of them are not employed. You know, those are some of the things that I talk with them about, you know, also getting family involved, you know, talking with, you know, discussing with their families. Further down, it does say lack of family support. You know, a lot of patients don't have, you know, family support. And sometimes that's where they get stuck because, you know, with transplant, they do need caregiver, they need a caregiver plan. They need to say, you know, this is the person that's going to take care of me after transplant. And then they need a secondary person. They need a backup just in case the first person can't take care, you know, if there's an emergency of some sort. So sometimes, you know, that stops, you know, the evaluation process because they don't have anybody that can take care of them after transplant. Literacy, you know, a lot of patients do need, you know, a little bit of time and explanation sometimes about, you know, what's happening, what's going on. I know I've personally been asked, you know, by a patient, you know, to come and, you know, sit in on their visit. And, you know, usually if they don't understand something, they'll look at me and then I'll try to, you know, explain it to them in a manner that they can, in a way that they can understand. And then of course, technology, for cell service. A lot of patients that come here don't have cell service anymore because the phones that they get are given to them from a program on the reservation. So sometimes, you know, I know their phones don't work, so it's hard to get a hold of patients and tell them that they have more appointments that have been added to their schedule. Lack of Wi-Fi. So, you know, because of these things, a lot of patients can't sign up for the patient portal. And another barrier that I discuss with patients is their cultural beliefs. I know that, you know, having a deceased organ placed inside you while you're still alive is something that a lot of patients have an issue with. And this is something that I ask them too. Is there anything, do you have any beliefs that would prevent you from having a transplant? And usually they'll tell me they don't have a problem with it. They'll tell me that they're going to have a ceremony, you know, once they start this evaluation. Sometimes they'll talk about, you know, having their medicine men come and, you know, do a blessing for them prior to transplant or even after transplant. I had one patient ask me, you know, has anyone talked to you? Have any of the Native patients, you know, talked to you about the, you know, after transplant? Have they been experiencing any issues from the deceased person's organ? Have they been visited by, you know, the deceased person? You know, things like that. Those are the kinds of questions that I get. So I'm always, you know, I'm always happy to answer those questions. And I know that Mayo Clinic here on the Phoenix campus is implementing a spiritual care center where they can provide, you know, cedar or sage so these patients can, you know, bless themselves or use that, you know, prior to surgery. So addressing the barriers, what I do, like I said, during the first visit when they first come here is I'll talk about transportation. I'll even help them with transportation, you know, setting up and making sure that they get to and from the Phoenix campus. Finances, you know, I ask them about, you know, is there anybody that can help you? Is there a way you can fundraise, especially for those patients that don't have access or Medicaid? The cultural beliefs, I usually tell them about the new center that we're going to be implementing, and then just making sure that they tell the providers, that they want their own medicine men, or they want some sort of blessing, even after the transplant or even before the transplant. Language and literacy. So I've been trying to work with Mayo Clinic to provide maybe a video of transplant education. And also they show video to the patients after transplant talking about their injection medications and labs, and very important information like that. So I want to try to get that translated into the most common languages that are here in Arizona, native languages that are here in Arizona. Technology, I always try to get patients involved with their family, try to get the family involved and try to get them to help with this aspect, trying to set up the patient portal, just asking, if they have kids that can help them navigate this. If not, then that's okay. I usually provide my phone number and say, if you think you have an appointment, or if you have, if you need help, just finding out when your next appointment is, feel free to call me, especially if they're not comfortable using technology. And then lastly, I like to connect with the referring provider or the social workers at the dialysis unit. This makes a huge difference. If I can't get a hold of somebody, then I'll reach out to the referring provider and say, this is so-and-so, and I'm trying to get a hold of this patient. Usually the social workers have been really good about, contacting me and asking me about specific patients that they have referred. And, I'll give them, a little update, or I'll tell them, he needs to contact us. He needs to call us because, they've tried to reach out to him a few times and he's not responding. So usually the social worker, talks to the patient because they see the patient more often than we do. So that's a good way to connect with the patient through the referring provider or the social worker. So again, I just want to thank Rena for inviting me here. When she had first asked me, I was like, I didn't know how to react to that, but I'm really happy that I accepted this invitation, and I'm very happy to share my experiences. I grew up on a Navajo reservation as a kid. I grew up around the language. I grew up around the elders. The picture that you see here, right behind that mountain right there, is where my grandma lives. This is in Indian Wells, Arizona. And as you can see, it's pretty remote. People have to drive distances to go check their mail. They have to drive distances to go get groceries. I saw a statistic that said that the Navajo Nation is the size of West Virginia. And within the Navajo Nation, there are only 13 grocery stores. And so just something to think about when you work with Native patients, when you work with patients that travel, quite a distance to be here. Yeah, and here's my contact information in case you have any questions or need to reach out if I can help you in any way with your patients. Thank you very much. And then questions, if you have any, I will try to provide answers.
Selena, no questions yet in the chat, just lots of appreciation for your great presentation. We'll hang out and I'll let you know if we get some here. Otherwise, maybe more will come up in our informal after meeting.
Sounds good.
I see that Ava Anderson raised her hand. Feel free to unmute yourself. I think we can unmute.
Okay, Ava, I just gave you the permission to unmute. You should be able to go and unmute now.
Yes, I would like to say that on our reservation, we also have the same problem with the language barrier. And so this is just this, how do we get past
I'm just to work on that.
the system, you know, to help our elders more with the cancer? That's all I was asking. Thank you.
Yeah, you saw me.
So in my experience, when I make that first call to the patient, I always assess for that barrier. I always ask them, do you feel you need an interpreter? And if they say yes, then I will try to make those arrangements prior to the patient arriving here on campus. I know that a lot of, like I said, they have iPads here in our facility, but an interpreter is not always available right away. I think in the state of Arizona, there are only maybe 3 Navajo interpreters and maybe 2 or so Apache interpreters. So I think, it just kind of, I know a lot of schools are teaching the Navajo language again. They're teaching these languages again. So I think that's a start. And I would encourage anybody out there that is, interested in doing this. It's a huge, it makes a big difference. It makes a huge difference, just being able to talk with the elders here in the hospital. Sometimes I get called, I get tapped on the shoulder and say, can you just meet with this patient? Because sometimes they do get transferred here emergently without family. The family's still traveling here to see their relative, and they're here alone. I met with one patient that didn't understand any English. He only spoke Navajo, only understood Navajo, and they couldn't ask him basic questions about, his current condition. They couldn't ask him, where are you hurting, or any of those things. So they asked me to come and see this patient. He was hard of hearing and blind in one eye. And, I went up to him, to his bedside, and I said, Yate, and he was shocked. And he said, oh, Yate. And, there's something about hearing the language and hearing the gratitude and the thank you in your own language. And it's just something that I really appreciate. And it just melts my heart every time I hear an elder, call, say, those are things that you hear growing up. And you don't hear that a lot anymore, especially when you're out here in the city.
Thanks, Selena. We've got another question from Carol asking, where did you get your patient navigation training?
So I didn't get training doing what I do. Everything that I've learned is all from experience. I have, my mom and my grandma, they both passed in 2020 from COVID. I worked with my mom a lot, with her appointments, and just talking to her primary care doctor about, their appointment, and just connecting with him, because my mom didn't understand. Sometimes she didn't understand, instructions. She didn't understand why she was placed on a new medication. So I would, call her primary care doctor and ask, what happened during the visit. And after, of course, with her consent, he would tell me, how their visit went. And then I would go ahead and talk to my mom and explain to her in Navajo, this is, why he gave you this new medication. This is why, he wants you to do this. So then she understood, and she said, okay, that's all I needed to know. And with my grandma as well, just talking to her about her blood pressure, talking to her about her blood sugars. That's where my experience comes from. Thank you for your question.
Okay, and then we have Angela's got a question. Angela, I'm going to allow you to unmute. You should be able to unmute now. Oh, go ahead.
Hi, my name is Angela. I'm a health promotion specialist here at the Tucson Indian Center in Tucson. My question is for your interpreters. I'm Hopi, Yaqui, and Pima, but we have a dominant Tohono and Navajo out here. Where would you suggest, or where do you find your interpreters? Like if you needed somebody who spoke Hopi, would you just go out into the community and ask, or do you have resources to that?
The Mayo Clinic uses a language line and also Pacific interpreters. These two are organizations that work specifically with Mayo, and they have a whole lot of interpreters that are available. You know, like I said, we have an iPad here and it just lists a whole lot of languages. And what you do if a patient needs an interpreter is you just, you know, push whatever language you need, and the interpreter is available video or, you know, as audio as well. But the problem with these native languages is, you know, I don't see Tohono O'odham as a language that's available. I don't see Yaqui as a language that's available. The only languages that I've seen so far are Navajo, Apache. There are 2 other languages that are available. So unfortunately, you know, when I do call these patients, I always ask, do you need an interpreter? And if they do, I haven't encountered the Tohono O'odham language or the Yaqui language yet. Hopi, I haven't had needed to request for a Hopi interpreter as well. So I think going forward, those are some of the things that I would consider in the future. And sometimes, you know, family can, you know, be there to try to help, but I know that with medical terminology, it's very hard.
Thank you.
And we've got just a couple more questions here, Selena. We're getting close to the top of the hour. We got one internally here from Mayo. Margaret Doherty is asking, hi, Margaret. Is Mayo considering ways to provide patient care closer to patients' homes? Do you know?
Not that I know of, but that is a very, that's something that I've been thinking about as well, you know, providing clinics maybe, or having doctors come out to the rural healthcare facilities. I would say like Fort Defiance or Tuba City or White River, San Carlos, some of those major healthcare organizations. So I think that's something that Mayo can consider and would benefit, you know, the patients at those communities.
And then 100%, I feel like what you just said is right on the money. Carol has a follow-up question, and I don't know if you completely understand this, so I might need to have her ask and clarify some more, but who are or what are some of the financial authorizers in the process? And so I'm not sure which process she's referring to.
Financial authorizers. Maybe when the referral is sent to us, usually we have a patient finance team that is specific to transplant, and they're the ones that reach out to the insurance companies and get specific authorizations for their visits. I don't know if that's what you meant.
Nothing else has come up in the chat, so I'm not
There's
quite
one in the
sure.
Q&A.
Ooh.
While you're pulling up that, I'm going to share my screen just to show a PowerPoint slide before we end this session. before Selena jumps into this next question, I just want to remind everyone, if you could please take our short survey to provide feedback on our webinar series. And also we do have a upcoming IHT speaker down in Arizona on November 16th, which you all should see a flyer coming out soon. But go ahead and ask the next question, Guthrie.
Well, I'm sort of wondering, well, all right. Selena, what advice would you give to healthcare workers that work in facilities that may not have the resources that Mayo has? How can we serve Native patients more if we don't have much to begin with?
That's a very good question. So Mayo started with implementing a position like mine, and I think it made a huge difference. It made such a difference that other departments here at Mayo are looking to implement similar positions in different departments. But my biggest advice would be to, if you have a Native patient that you're treating, I would say, just to be patient with them. I know a lot of Native patients, they don't like to rush into a visit. They don't like to rush into a conversation. I know, doctors are, always in a rush, and they have a certain amount of time to treat this patient or see this patient. But, a little patience goes a long way. And sometimes if you also, kind of get an idea of where this patient is from, or, even just try to learn, what tribe they're affiliated with. And I know, it makes a huge difference when you greet these patients in their native language, that tells them that you acknowledge them, and where they're from, just little things like that goes a long way.
All right, awesome. Thank you, Selena. Those are really great questions and answers. Selena is a very strong advocate for our Native patients there in Arizona. So I'm really happy that we were able to get her to speak for our Indigenous Health Topics speaker series. If anyone has additional questions, please feel free to click on the Zoom link that Guthrie dropped in our chat to join us for a little after session to have more direct questions with Selena. Thank you all again for joining us today, and look out for our upcoming Indigenous Health Topic speaker on November 16th again. So I think we'll leave this open just for another minute so everyone can click on that link and join us in a little bit.